for questions. During my section, if you want to unmute your line to ask a question or throw a question in the chat room, please do that. And always know that you can contact me after today's session if you would like some additional information or you would like further clarification about the things that I discussed today. So please don't hesitate to contact me. And you can just contact me at alexandra.andric@camh.ca. Okay, so let's begin. So I'm going to be talking about psychosocial interventions. And so when we look at the CanAdapt guidelines, we see that people who have been diagnosed with a mental illness or who experience mental illness and maybe haven't been diagnosed have a higher prevalence of smoking, and it's more difficult for these individuals to quit smoking. And that may be because of access to treatment, could be stigma, could be, people often in mental health may not look at helping people with smoking. Maybe they're looking at helping people be stable with their mental health. And then in the addictions area, maybe they're not looking at mental health, more so addiction. So sometimes because of these silos, people aren't getting the help that they need. And yet, at other times, people are getting that help. So I know there's a lot of people who work in addictions and mental health who discuss concurrent disorders and help people with concurrent disorders. So I just want to put that out there too. But what we know and what all of you already know is that we want to offer counseling and pharmacotherapy to persons who have been diagnosed with concurrent disorders to give them the best chance possible to make this change. And treatment may be a bit longer. And as you all probably know, we still are going to be using our standard psychosocial interventions with some adaptations. Unfortunately, there may be some things that I discussed today that aren't new. Maybe there's a couple new things I will be putting out there, but I just wanted to let people know that there isn't much new out there right now. So how do we help these individuals? Well, the first thing we want to do is we want to screen all the clients that we see for any mental health challenges. And if I think about where I work, a lot of times people may not know what the criteria for depression are, and they may have the symptoms of depression but never had a word for it or a knowledge about it. Same with anxiety. So you want to screen people and ask them if they're having any mental health challenges, and if they are, to ask them to elaborate on those challenges. We also want to ask every client that we see about their tobacco use, just as part of our regular point of care. Just, as a nurse here at the clinic, I'm doing a person's vitals, so this would be another thing for me to do. Maybe if I was not at a smoking cessation clinic. So that idea of this is just part of our normal care to ask people about their tobacco use. Then we want to kind of conduct a brief intervention about mood. So we always want to ask people about their mood as they go through this change process. We may, if we have the criteria for, actually I should say that differently. So we, hopefully people know the symptoms of depression, symptoms of anxiety, so they already have that knowledge, so they can ask clients about what they're experiencing, explore a bit more. Some people may use the PHQ-9 to assess what's going on with that person in terms of depressive symptoms. You can also use the Generalized Anxiety Disorder Scale 7, it's called, to assess anxiety. What's also important is to kind of tease out whether these mood changes, are they associated with withdrawal? Because we know sadness is a withdrawal symptom. Is it associated with, hey, I've lost this thing that was with me through thick and thin, and now I'm no longer having this thing, meaning the cigarette or tobacco. So could it be a loss about having that part of them gone, like the use of that cigarette for a friend, so to speak? Also, some people you may find, or you have already found, that people may have an identity that's kind of tied up with smoking. And so sometimes people have to go through a grieving process. Also, people may be experiencing a depressive episode because we know tobacco has mood elevating effects. There's beta-carbolines that elevate mood. So it's important for us to get the full picture and kind of figure out what's going on there. Then what we want to do is we want to recognize and address these issues. So if it's a question of withdrawal, is this person using nicotine replacement therapy? Do we need to increase the nicotine replacement therapy? Is the person experiencing the grieving process? So we want to talk to them about that and work through that with them. Or do they need more intensive help in terms of depression and anxiety? And where can we send those people to, or what can we give them to help them out? So when we think about what we're going to do in terms of someone is telling us they have been experiencing symptoms of depression or anxiety, I just don't know what happened there. One moment, please. I got it.
Oh, the slides went away. Did you press stop sharing? Sorry, everyone.
I don't know. I thought I was just moving it forward.
Oh, no, that's okay. We'll just make this bigger.
Sorry, everybody.
Okay. No, that's okay. It happens. Sorry, everyone. Just 1 second here. Just going to re-upload the slides.
And then you're going to show me where to press, since I obviously pressed the wrong spot. Today's the 25th.
Perfect.
So I think we were at clinical considerations, and when we think about clinical considerations, someone with mild to moderate depression may need different interventions than someone with a more severe depression.
Okay.
Okay, perfect. And
Can everyone see everything?
Yes, thank you.
You're welcome.
Okay, sorry about that, everyone. Thank you for your patience there. So I was talking about people will have varying levels of depression or anxiety, and depending on the severity, the clinical interventions we use will be different. So the foundation for all treatment is brief intervention, which I'll talk about momentarily, and educational resources. The more intense treatments would come if you're someone who has background in mental health and can help those individuals, and they would see you about their anxiety and or depression, or it may mean a referral to another area. And we know that adding psychosocial mood management components increases long-term cessation rates in smokers with both current and past depression compared to standard interventions. So as you can see in this diagram, when people may be experiencing minimal depressive symptoms, what we want to offer is educational resources and brief interventions. So those educational resources I'll touch on in a little bit, and also at the end of today's session, Stephanie will be sending out 2 web links, one which was developed by our clinic here, and then also a self-management mood workbook that can be downloaded. We will also provide that website address as well. So what are these brief interventions? Well, the brief interventions are basically, we're looking at making that having a conversation about how tobacco and mood are associated. We want to look at the readiness scale, so how confident and how important is it for this person in terms of quitting smoking? Is it important to them? Are they confident in it? And then lastly, the other bit we're going to be looking at is we're going to look at making a plan together with them and using those SMART goals: specific, measurable, attainable, realistic, and timely. And then as you can see, as we work down this slide, that as people are, if we look at the last slide with major depression, severe severity, we want to provide those resources. We want to do that brief intervention. We want to make sure that the person's open to or have a discussion about maybe doing combination therapy, meaning an antidepressant and counseling. And you can see in the other variants of depression that people may have an either pharmacotherapy or psychosocial interventions, something like CBT, ACT, or mindfulness for depression, for example. So when we look at what can be helpful with these individuals who experience both anxiety and depression, or strictly depression or strictly anxiety, you can see a myriad of different psychosocial interventions here. I'm sure a lot of them you know already. So I'm going to very briefly discuss them to maybe remind you. Okay. So motivational interviewing is a way for us to help people resolve ambivalence. So it's natural for people to feel like they want to change, that they don't want to change, and to be jumbled up about that. And when we use motivational interviewing, what we're really trying to help people resolve their ambivalence by looking at kind of what their thoughts are about changing their tobacco use. So we're going to be using our spirit of motivational interviewing, so compassion, acceptance, partnership, evocation. We're also looking at using our micro skills, open-ended questions, affirmations, reflections, summary statements in all the 4 processes. So, at the beginning when we're first engaging with someone, we want to establish that therapeutic rapport. We want to hear about their thoughts about making a change in tobacco use. What are their thoughts about that? And then when we're focusing, once we've established that rapport, we want to work together to figure out what is our common goal, and try to elicit the change talk, and then recognize it, and then also keep discussing when people have a desire, ability, reason, or need to change, so that maybe they may become more committed, maybe they're going to be interested in activation and taking steps. Okay, and then lastly, the planning part. Planning part meaning people are ready to make that change, and they've asked you for information, or they have said comments to you that say, you know what, I'm ready to do this. Psychoeducation, basically, you're letting people know about the association with mood and tobacco use. You're talking about the importance of the 4 Ds, distract, delay, drink water, deep breathing. You could talk about avoid substitute change. You could talk about the medications that can help people make a change in their tobacco use. You can talk about stress management. So really you want to use plain language. And when I think about providing information for consequences, you sort of want to, really depends on your audience, because for some people, if they hear very negative things, they might feel like, okay, well, what's the point? I'm not going to bother making a change because, you know what, I already have COPD, but it's done, I'm done now. And so thinking about, who you're working with, because other people may, if you provide also that information about how you can stop the progression of the illness by quitting smoking, this could be a hopeful point. So I'm also thinking about it might be helpful to talk about how the body and mind can be in a much better state when you quit smoking. So I think that's an important thing to talk about in psychoeducation as well. Cognitive behavioral therapy, an intervention that can be used both in anxiety and depression. And really what it's about is, as many of you may already know, is looking at your thoughts, feelings, behaviors, and finding evidence for and against those thoughts. Because for a lot of people experiencing depression, for example, it's going to be all negative. And we're not trying to say to people that, hey, your thoughts are always wrong. What it's really about is letting people look at, okay, how true is this thought about myself, especially because I am feeling depressed right now and I am in kind of a negative headspace. So it gives people an opportunity to evaluate, to identify, and maybe make tweaks in the way they feel about things and the behaviors they will perform, because they're kind of looking at things a bit differently, because people are influenced by the people around them, messages that were sent to them as children, and then strategies they learned growing up. So, if I have a feeling that I'm never going to be able to do anything, and this was something that was, my parents weren't very helpful, and my friends also put me down, I might have the thought that I may never be able to quit smoking because, you know what, I have issues. And so through CBT, I may be able to change those thoughts about myself, and it's really about the here and now. The stress management resource is something that we have created here at NDC that can be provided to clients, and in here we have information about internal, external supports out in the community. Connex Ontario can tell people about where they can get treatment for depression and anxiety. There's a mental health line that they can call there. Talks about behavioral activation, one of the key components in helping people when they're first depressed is, helping them get going at things, tracking, and another example may be diaphragmatic breathing. The thing with the breathing low in the belly may be hard for people who have been diagnosed with COPD, so talking about pursed lip breathing can be helpful. Some of you may already know this, where you're taking a couple, the count of 2 of breath through your nose and then blowing out the breath at the count of 4 like you're blowing out a candle. This sort of thing. So these can be helpful for individuals with COPD if they have difficulty getting into that breathing into the belly. Breathing into the belly will get the relaxation response going, and you can't be relaxed and stressed at the same time. Relaxation and stress, recognition and exercise. We know that people, another kind of first intervention for depression as well as anxiety, exercise. This can be helpful. It releases endorphins and maybe helps people kind of get their frustrations out. Visualization can also be helpful as well. Acceptance and commitment therapy really takes components of mindfulness, where people are kind of accepting of the situation that's going on. So it incorporates aspects of mindfulness practice to help individuals build awareness and de-stress tolerance. It focuses on accepting things outside of one's personal control and be willing to experience discomfort or distress, as well as committing to action that can improve and enrich one's life. So people aren't actually, so with CBT, you're trying to, look at your thought. Your thought is problematic. What is my evidence for and against? Well, actually, maybe I can take a more balanced way of viewing things, because, all this evidence that I thought or perceived against me wasn't really happening. With acceptance, with ACT, what you're looking at is you're just in the moment, and that's where this mindfulness piece comes in. So acceptance of what's going on right now and the things that you have no control over. Diffusion is the idea of recognizing images, memories, what's going on, and being non-judgmental about it. So what you're feeling right now is what you're feeling right now, without any judgment or self-criticism. Self as context is this idea of I can have my own concept of self without it being influenced by my thoughts, my feelings or bodily sensations. Then focusing on values is really, the client will explore what's important to them, how they want to live their life, what is valuable to them, and then committing to those values and living in a way that supports those values. And we can see that ACT-treated smokers have significantly higher cessation rates and lower levels of depression and anxiety compared to those who are treated through psychological counseling. So the thing is with ACT is we still don't have a lot of research, so it's promising. That's a for sure thing. So this is something that might help people as well. Mindfulness, very quickly, I'm going to take 2 more minutes of everybody's time. Mindfulness is really being in the moment right now, forgetting about the past, the future, and when things are coming into play, that you sit with it. It is what it is, and maybe by focusing attention on the body or on breathing, people are able to decenter and make better decisions. So this can be used both for anxiety and depression, and can be used for surfing, urge surfing, when people have those cravings to smoke. Social support, you can see here that it's very helpful because a lot of people may not have people out in the community who know what it's like to quit smoking, so having social support can be very helpful, especially in the form of group, besides you individually. And group counseling, better bang for your buck. You can see a lot more people. People can have that same boat phenomena. Hey, there's someone with depression. I have depression. What are they doing to quit? Oh, that's very helpful, what they shared with me. Also, you're going to have a lot more people having different points of view that can be helpful for the client in terms of thinking what could help them out. Okay, and finally, relapse prevention. We want people planning for the high-risk situations. When we think about functional analysis, you're looking at, what is causing the craving, what is the person's behavior, and what are the long and short-term consequences, and what are the long and short-term benefits, so that people can kind of see the use of smoking, what it's helping them with, and what are things that they can do differently. Okay, so I'm going to pass it off to Milan, or Dr. Khara, I'm sorry I took an extra 4 minutes, but I'm going to pass it to you now. Thank you, everybody.
Thanks, Alex, and thank you, folks, for listening in today. I am a little technologically challenged myself. I'm not in Teach Mission Control. I'm in Vancouver on the West Coast, and I'm going to be asking Stephanie or one of you folks there in head office to flip slides for me. But on slide number 30, just to open up and introduce, to give some context to what I'm going to talk about. I'm going to talk about medications only. That's not to say that what Alex has talked about is not important. Of course it is. When we treat those who have tobacco use disorder, we take this bimodal approach. We do the behavioral counseling, or the psychosocial treatment, whatever you want to call it, and we do the pharmacotherapy or the pharmacological interventions. Both are equally important. I do my clinical work from a hospital-based clinic where we see individuals with tobacco use disorder who are either referred by other disciplines, sometimes by cardiology or cancer services, and sometimes they're self-referred, sometimes they're staff, and certainly depression and anxiety are very common co-occurring disorders. And I'm going to talk mainly about how we approach those patients who are somewhat stable. These are the folks that we all see moving around within the system, certainly with symptomatology, sometimes doing less well, sometimes doing better. But I'm not really talking about the kinds of folks that we see with severe symptomatology who may be admitted to psychiatry. For those individuals, I think what we do is withdrawal management. I think most of you will be familiar with a patient who's admitted to hospital, who smokes a pack of cigarettes a day. We should be putting patches on those individuals in the era of smoke-free hospitals to keep them comfortable what we're doing there is usually not really cessation. I'm not really talking about those patients. I'm talking about the kinds of folks who are, as I said, flowing in and out of our system, who may well be struggling with their co-occurring mental illness, but who certainly may well be appropriate to at least begin the process of cessation. Okay, so I hope that's a good intro to what I'm going to talk about. Again, I'm going to leave 10 minutes at the end for questions, which I think will hopefully be the most important part of this session. Flipping to slide number 31, how do we help? Alex has already shown this slide, but again to make the point that what we do with those with co-occurring depression and/or anxiety is essentially what we do with the so-called general population smoker. We provide pharmacotherapy and counseling. It's really not very different, but there are a couple of important caveats. And the first is that our treatment may well be longer. We understand that these patients can find it more difficult to quit and are less likely to be successful. They may also be more heavily addicted or more dependent. So we may extend our pharmacotherapy beyond the standard 12-week intervention. It may be that we go to 16 or 20 or 24 weeks, or frankly, whatever is required. In the province that I work in, our government covers only 12 weeks per patient per year, so there can be obstacles around the extending of pharmacotherapy, but in principle, we certainly are open to treating for longer than the label recommends. We go off the label in terms of treatment duration. Our treatment may also be more intensive, and in the context of pharmacotherapy, what we mean by that is that we may need to combine medications. We may need to go above and beyond standard dosing. Again, these are areas that we at one time used to call off-label. Increasingly, they're actually within the label, so combination NRT, for example, is no longer off-label. But putting 2 patches on somebody certainly is. But these are the kinds of ways in which we titrate up to doses that may be required in harder to treat populations. So these are kind of standard approaches with pharmacotherapy that we use in these populations. Moving ahead to slide number 32, most of you will be familiar with the tools in our relatively limited pharmacotherapy toolbox. I'll run over them just for review as much as anything else. Of course, we have the first class, the nicotine replacement therapies. We have patch, 3 sizes, 21, 14, and 7. And then we have the so-called short-acting NRTs, gum, inhaler. We don't have the nasal spray in Canada, but we do have an oral spray, and we have the lozenges. Those last 4 options we would call the short-acting NRTs. And again, just thinking for a moment about intensifying treatment and going with a combination, which we know is more effective in promoting cessation than using a single agent, we might go with a patch, the long-acting delivery of nicotine that reduces craving, and we might add one of the short-acting NRTs as a means to deal with cravings or craving situations as and when they occur. So in my practice, somebody wearing a patch and carrying a pocket full of gum so that when they walk around the corner and see their friends who they smoked with for 2 decades standing smoking, they can reach into their pocket, take a piece of gum, get a little bolus of nicotine, and hopefully navigate that particular craving situation. The other thing that we need to remember with the NRTs is that the concept of reduce to quit is no longer considered off-label. And what we mean by reduce to quit is the use of NRT with concurrent smoking. So if we go back 2 decades, putting a patch on somebody meant that you had to quit today and never smoke again. Whereas today, we increasingly say, look, you can put a patch on. If you continue to smoke, nothing bad's going to happen to you, but use the patch to support reduction. And let's make incremental goals and see you a few weeks down the road when hopefully you've reduced by 25 or 50% or whatever you are able to do, and then make new goals at that point. So reduce to quit is a nice way in for those who lack confidence in cessation, those who may be heavily addicted and feel that they're unable to make progress. And that often is the case with these populations with co-occurring illness that we've been speaking about this morning. So reduce to quit is something that, again, commonly we use in our clinical setting. The second class of medication you see there is the antidepressant class, so bupropion SR, also known as Wellbutrin in its antidepressant guise, but known as Zyban in its smoking cessation guise. This is a medication that we actually don't use very often these days, not least because its side effect profile is not the best. Bupropion quite commonly causes irritability, anxiety, insomnia, and these kinds of symptoms are certainly in those with generalized anxiety disorder not ideal, and even in those with depression, often it's a medication that's not very well tolerated. Having said that, it is from time to time used by some practitioners who are attracted by the idea of treating both disorders with one drug. So for those with depression who are using tobacco, the idea that there'll be some relief of depression and some reduction in tobacco craving is attractive. It's not a particularly evidence-based approach, but it's one that could be considered. My preference would be to use a better agent to treat depression, one of the modern SSRIs, and use a better agent for smoking cessation. I would tend not to go for bupropion unless someone had specifically requested it on the basis of it had been effective in the past or for whatever other reason. A relatively rarely used medication, certainly in our practice at UGH. And last but not least, there you see the third class of medication, the nicotinic acetylcholine receptor partial agonist, bit of a mouthful, but varenicline works by landing on the same receptor that the nicotine molecule will land on in the brain. It has partial agonism, so in other words, it kind of mimics the effect of nicotine and leads to the release of dopamine in the brain, which tends to reduce craving. But it also has a secondary effect whereby it blocks the effects of nicotine in the brain, so that if the individual who is taking varenicline does smoke, they tend not to feel the effects of smoking, and thereby reduce the reinforcing effects of cigarette smoking, and thereby make it somewhat pointless. And so varenicline has this dual action, and we believe that it's this dual action that makes it the most effective oral agent, and certainly the most effective monotherapy. The effectiveness of varenicline in trials is similar to the effectiveness of combination NRT. So that's a quick review of the medications. Moving on to slide number 33. You're all familiar with this slide. I won't spend too much time on it, but of course this is why we're having this conversation today. We know that the prevalence rates of tobacco use in the subpopulations of individuals with co-occurring depression or co-occurring generalized anxiety disorder or co-occurring schizophrenia are super high. They're 3 to 4 times the rates that we see in the general population. Alex touched on briefly why this may be the case. We know that the self-medication hypothesis has some legs and may be at least partly the reason why we see high rates of smoking amongst these populations. But the really important thing is that when we set up smoking cessation services, whether they're within psychiatry or whether they're in other parts of our system, these are the folks who are increasingly turning up. As our prevalence rates in this country drop down to these relatively low numbers of 12 or 14%, in my province maybe even below 10%, when we have services for those who use tobacco, more likely than not, the folks that you see will be those with these co-occurring illnesses. So we need to certainly be cognizant of that and factor them into our treatment approaches. Okay, so moving on to slide number 34, this is just a little reminder that the often well-held belief by patients that tobacco use is improving their mental health and that the loss of tobacco will lead to a worsening of depressive symptoms or symptoms of anxiety. Even though there is some evidence to actually support that, there's at least one study that suggests that those with major depression who, when they quit smoking, are more likely to have an episode of depression in the subsequent 6 months. There's actually now a growing body of evidence that actually supports the idea that those who quit actually will feel better. Maybe not initially, but actually will feel better. And this slide that you see, slide 34, is from a systematic review that was published in the British Medical Journal a couple of years ago. And what that study did was gather together a whole bunch of smoking cessation studies and actually compared those who quit with those who continue to smoke, and applied a whole bunch of standardized tools for measuring depression, anxiety, stress, and quality of life. And what that study actually found was that those who quit compared to those who continue to smoke had reduced scores on depression, anxiety, and stress scales, and actually improved scores on positive mood and quality of life scales. And interestingly, that was the case in those with and without psychiatric disorders. So there was a group of individuals within this study who were identified as having established mental illness, and those folks saw these improvements, as did those who didn't have mental illness. And they tried to assess the size of this effect, and it was found to be similar to that of SSRIs. So if one wanted to underline the point, if you were presented with an individual with depression and who uses tobacco, and you could only do one treatment, of course we can do as many treatments as we want, but if you could only do one treatment and your choice was between stopping smoking and using an SSRI, you could reasonably say, let's help you to stop smoking, and that may well have as positive an effect on mood as using the SSRI. Of course we would do both, but just to kind of make the point that smoking cessation for these patients actually can have tangible benefit. I would encourage you to look up that study if you get a moment. So that's British Medical Journal from 2014, Gemma Taylor and colleagues. Okay, and now for the last few minutes, I'm not really sure how familiar all of you folks are with the EAGLE study. I'm sure many of you will be at least aware of this study, but the reason for just walking through the study again is that it's a bit of a kind of a stubborn myth that patients with diagnoses of depression and anxiety need to be careful around their medication choices, and that maybe varenicline, for example, is contraindicated in some of these populations. And there's reason to believe that we need to be cautious based on the way that this story with varenicline in particular has evolved. The medication arrived on the market in 2007. There were these sporadic reports of some individuals getting into trouble with reports of depressive symptoms, with reports of suicidality, and with a number of reports of actually completed suicide. And these kinds of reports led to the changes that we saw in the labeling by Health Canada and the FDA and others. And eventually we ended up with the highest level of warning in this country, short of removing a medication from the market, and that is the boxed warning. And within the boxed warning was verbiage that said, to the effect that this medication should be used with caution, particularly in those with pre-existing mental illness, and if there is the emergence of mood symptoms, the medication should be discontinued. And this was advice to healthcare professionals and to patients who may be taking this medication. And this story led to the request, maybe a demand by our regulatory agencies for the manufacturers of this medication to actually do a trial, a large trial, to try and answer whether in fact there was an increase in the risk of neuropsychiatric side effects with this medication. And that led to EAGLE. And I'll very quickly walk you through the EAGLE study. So as you see from slide 35, this randomized controlled trial of 8,000 plus subjects looked at actually 4 treatment conditions. And these 4 treatment conditions were varenicline, aka Chantix, bupropion, aka Zyban, nicotine patch, and placebo. So our 8,000 patients got any one of those 4 treatment conditions. They were all completely blinded, and those 8,000 patients were divided into 2 cohorts. And this is the really important part of this trial. Those 2 cohorts were separated into those without mental illness, the usual kind of study population that you see. But in this trial, one cohort of 4,000 patients were those who were considered to have a mental illness, a stably treated history of mental illness. So now we were looking at these medications in the kinds of populations who somewhat we see in clinical practice. I mean, whether they're as stable as whether they're more stable than the patients we see day to day, that one could argue about that, but this has really been the kind of best collection of patients that would be somewhat similar to what we see in our day-to-day practices. So 2 cohorts, 4,000 each, 1 psychiatric, 1 non-psychiatric, and separated into 4 treatment conditions: varenicline, bupropion, nicotine patch, or placebo. 12 weeks of treatment. I'll flip to the next slide. Apologies, this looks a little busy, but all you really need to see there is that these 4 treatment cohorts had 12 weeks each of varenicline, bupropion, patch, or placebo, and then we followed them for a subsequent 12 weeks as well, so 24 weeks of follow-up. And then I'll flip to the next slide, which shows you what we were looking for. This trial was designed to look for this so-called composite neuropsychiatric endpoint. In other words, we were looking for any one of the things that you see on that slide: anxiety, depression, hostility, agitation, panic, etc., etc. Any one of those reported symptoms, which were also sought by providing standardized questionnaires, any one of those symptoms would be notched up as a plus on the neuropsychiatric endpoint. And we were looking to measure those throughout the trial in these 4 treatment conditions in our 2 cohorts. And I've now flipped ahead to slide 38. I'm going to spend a couple of minutes here just to show you the results of this trial. I hope everybody's still with me. I realize this is a bit of a mouthful, and I realize it's moving pretty quickly, but this is really the bit that we need to understand because it tells the story. So this slide 38, our primary endpoint, shows us in the top horizontal line the non-psychiatric cohort in the light blue. When we work from left to right, we see that the event rate in the varenicline cohort is 1.3%. We move 1 block to the right to the bupropion cohort, we see that the event rate is 2.2%. When we move a block to the right to the NRT cohort, we see that the event rate is 2.5%. And when we move 1 more block to the right, we see that the event rate in the placebo cohort is 2.4%. What you need to know about those numbers is that there's no statistically significant difference. In other words, in the non-psychiatric cohort, the psychiatric event rate was no different between varenicline, bupropion, NRT, and placebo. Pretty important result. And when we move down to the psychiatric cohort, in the slightly darker blue below, and we work across the numbers, you'll see 6.5% for varenicline, 6.7% for bupropion, 5.2% for NRT, and 4.9% for placebo. 2 things to observe here again. The first is that, again, no statistically significant difference. So in the psychiatric population, in this study, whether we gave them varenicline or placebo, there was no difference in psychiatric side effect event rates. But what you'll also note is that the numbers in the psychiatric cohort are quite a lot higher than the non-psychiatric cohort. So what this tells us is that when this population attempts to quit smoking, their likelihood of having an event is actually higher. It's not agent-specific. It's not varenicline or bupropion or patch or placebo because they're all the same, but they are more likely to have a neuropsychiatric event. And really, this makes our point, maybe our take-home point for today, that when these populations try and quit, they do need to be monitored more carefully, and we do need to be prepared to either optimize their counseling or optimize their SSRIs or even bail on smoking cessation. If an individual becomes suicidal and tells us that they can no longer continue, we absolutely need to support that and optimize their psychiatric treatment. So that's the EAGLE study. I realize I've gone through that rather quickly, and apologies for that, but it's one that I would encourage you to seek out if you have questions about the use of medications in this population. I will flip ahead to slide 39. This is just the 5 A's. Most of you, I think, will be familiar with the 5 A's, this concept of brief intervention that we apply to all populations. We ask a couple of brief questions. We ask, we advise, we assess, we assist, we arrange. These kinds of interventions take a couple of minutes, and we know that when we do this, we increase cessation rates in the general population. What you see here in front of you is one that has been modified by Charles Else, a psychiatrist from Edmonton, and modified to include the brief mood assessment, and whether we use the PHQ approach or whether we ask a few appropriate questions about mood and suicidality in vulnerable populations. This is a sensible modification of the 5 A's, so we make sure that we're not missing those who are vulnerable and who, if they do begin to reduce or quit smoking, start to get into trouble. We'll move ahead to slide 40, which is my final slide, and I will just make a very brief point. Of course, I know people can tie themselves into knots when we come to talk about electronic cigarettes, and we could spend a number of hours discussing the pros and the cons, but just a quick mention to some of the conversations that are happening about the use of electronic cigarettes potentially in these subpopulations. For example, the populations who are admitted to psychiatry, who find cessation difficult, who find the use of NRT for withdrawal management difficult. Is it viable to put the electronic cigarette into the hands of these folks? I think there are a great deal of problems with this idea. I don't think it has been fully thought through or fully evolved, but I think it's important to acknowledge that these conversations are beginning to happen in some parts of the developed world. The debate needs to occur, and we need to reach a sensible conclusion, but we're not there yet. So just a nod to the potential utility of e-cigarettes in this population at some point in time. So I will stop there and open it up to questions. I think I've left 10 minutes, questions for either myself or Alex. I will, I think, unmute my line so that others can hopefully chip in.
So, hello everybody, I'm back again. It's Alex here. Milan, you've got a question there. Any effectiveness rate differences when using Champix or Zyban for the depressed population?
That's a very good question. Champix or Zyban efficacy in trials for the depressed population. First thing to say is that in the general population, it looks like from a couple of different studies, Eagles and also a nice Cochrane network meta-analysis, which is kind of a lumping together of lots of different studies. It looks like varenicline is about 1.5 times as effective as bupropion. This is in the general population. I don't think we have enough data in the depressed population to say that one agent is more efficacious than the other, but I think I would project from what we know about the general population and say that it's highly probable that varenicline is a bit more efficacious. And if I was presented with somebody with stable depression who didn't have a preference, I would recommend the use of varenicline because it would appear to be more efficacious based on our general population studies, and because its side effect profile is probably preferable. Again, that would be qualified by somebody telling me that they've had a good experience with one or the other and they would want to use one or the other, then sure. But somebody who's a blank page, I might be more inclined to go to varenicline based on probably more efficacious and probably less problematic day-to-day side effect profile.
Thanks, Dr. Khara. There's another one here because From Claire, we've got, are you aware of any studies regarding the use of e-cigarettes as a tool for mental health clients to quit smoking? So Claire, I have no ideas about this question. Dr. Khara, any ideas?
Okay. So this was why I kind of used slightly. This is why I tried to go quickly over my e-cigarette slide, because once you open the Pandora's box of conversation on e-cigarettes, we can go into a very deep and dark hole. Of course, I'm joking. It's all fascinating stuff. Generally speaking, and I try to be as even-handed as possible because there's a wide variety of views on e-cigarettes. Most of you will know that, and that we're a long way from consensus. But generally speaking, the evidence for e-cigarettes as a cessation tool generally is weak. And increasingly we're seeing studies which seem to actually be suggesting that e-cigarettes might even be an impediment to quitting smoking. Now, some of you may be screaming that you disagree with that because you've seen other studies, and this is part of the problem, is that there's a bit of a cherry picking of studies. So it's really hard to be even-handed, and most of us tend to show our bias a bit here. But it's hard to be strongly supportive of e-cigarettes as a good cessation tool at this time. And as far as I know, there is no good evidence that they're a particularly good cessation tool in the subpopulation of those with depression. If anybody has something that they'd like to say that is contrary to that, I'd be more than welcome to hear their thoughts.
Okay, so wait and see there. The next question is from Lita City Center Healthcare. When reducing to quit, is it still 1 milligram equal to 1 cigarette? So it's interesting because when people reduce, as Dr. Khara talked about, reducing to quit can really help people who don't have a lot of confidence in their abilities to do so, and then it's affirming to them to see, hey, I got rid of some of these cigarettes. Sometimes people can become more efficient smokers when they reduce, meaning they may smoke that cigarette from beginning to end and hold in that smoke a bit longer. So sometimes, because people want to have that amount of nicotine that they're used to, so sometimes they may be more efficient smokers. And so in my travels, I've heard that people can get between 1 and 3 milligrams of nicotine per cigarette, depending on how efficient they are. So Dr. Khara, did you want to add any thoughts to that?
Yeah, thanks, Alex, and thanks for the question. It's a good question. I guess to take a step back from the question, our general approach when we see tobacco users and we choose the dose of patch, as most of you know, I'm sure, is that we approximate 1 milligram per cigarette. So if somebody smokes a pack a day, we start them on a 21 milligram patch. If somebody smokes 12 cigarettes a day, for example, we tend to go with a 14. That's been generally our approach. The first thing I would say about that approach is that it's really a guesstimate for the starting point. And the reason it's a guesstimate is because of what Alex has just alluded to, and that is there's a varying degree of efficiency in smoking for all tobacco users. So sometimes the 21 milligram patch is enough, but sometimes it's just not enough. So the guesstimate should lead to a starting point. And if you give a 14 milligram patch to somebody who smokes 12 cigarettes a day, and you see them 2 weeks later and they're not having much success, and they're craving like crazy, and they've not reduced much, then that should lead to an increase to a 21 milligram patch. The starting point is not really that important. What's more important is how you titrate to effect. And I know that's not what is done in most general settings. I know it's not what's done by most general practitioners or even pharmacists, but it is what we tend to do in these kind of specialist dedicated smoking cessation settings. Now, to answer the question specifically, what do you do in the reduce to quit setting? Well, there's no real evidence to inform what do you do in the reduce to quit setting, but we have generally tended to do exactly what we do in the non-reduce to quit setting. So if somebody smokes a pack a day, we tend to start with a 21, and we encourage reduce to quit, and then we go from there. And if somebody's doing really well with reduce to quit, we might not need to increase the dose of patch. If they're doing less well, then we probably would.
Okay, so I'm noticing that our time is 1 o'clock, so I'm going to pass it off to Stephanie. And I also want to let people know that there were still a couple questions, so we will get those, we will comment to those questions. We'll send out some emails. Thank you so much for taking time out of your day. Nice to hear you, Dr. Khara, and take care. And I'll pass it off to Stephanie. Thank you, everybody. Take care.
Thanks, folks. Nice to talk to you, Alex. Bye-bye.
Bye.
So thank you so much, Dr. Khara and Alex. That was a very informative webinar, and thank you to everyone who attended. The chat was very engaging. My apologies for the technical difficulties. However, this webinar has been recorded, and I will be distributing the slides so you can share it with your colleagues as well as a link to the recording. So remember, a link to the evaluation post-learning assessment will be distributed this afternoon, and you will have 1 week to complete it if you would like a letter of completion. If you participated as a group, please email teach@kmh.ca with a list of the names of those who attended by 2 p.m. Our next Teach Educational Rounds is August 15th, and I will be sending out a registration link with your post-learning assessment email, so you can look forward to that as well. And again, if you have missed today's presentation or are interested in viewing it again, a list of our archived webinars are found on our website, so you can